and welcome to the Dr. Bob Show. Do you have trouble with your stomach? Are you not sure what the stomach problem is? Could it be diverticulosis or diverticulitis? We'll be spending most of this show talking about the difference between those two stomach problems, and both can cause significant problems. My guest is Dr. Raj Narayani. Dr. Narayani is a board-certified gastroenterologist. He deals with diverticulosis and diverticulitis every single day. He'll be answering our questions. Hello, I'm Dr. Robert Overholt. I'll be your host for the next 30 minutes on the Dr. Bob Show. And later on, we'll be talking about a wake-up call. Is your blood sugar too high? If it is, it should be like a deer in headlights. It's something we have to pay attention to. And new findings on the aortic valve. Why is there some people that get calcification on the aortic valve that can lead to heart failure? A lot of information for you. You'll want to stay tuned. We're talking with Dr. Raj Narayani, and we're talking about diverticulitis and diverticulosis. Do you know what those mean? We're going to find out. Raj, welcome to the Dr. Bob Show.
Thank you for having me.
Tell me about the words diverticulosis and diverticulitis. Where are they and what do they mean?
So it's interesting, those two words are probably the most commonly confused words that I deal with when I see patients in practice every day. Diverticulosis is an anatomic term that simply means pockets forming in the wall of the colon. So they are typically in the lower part of your abdominal cavity in your colon, most commonly on the left-hand side of your colon. And if you got up real close to the colon wall to see it, maybe at a microscopic level, what you'd realize when you see one of these pockets is that it's essentially a herniation or a bowing of the colon tissue through the wall so that you form this pocket essentially. And many pockets will typically form over a section of the colon.
Does everybody have them?
Lots of people have them. They're very common. The data suggests that 20% of people over the age of 40 will have them, but by the time we look at people over the age of 60, up to 60% of people will have them.
Wow. So it's an outpouching, a bubbling out. About how big are they?
They're typically maybe a quarter to a half an inch big.
So do they cause problems?
Usually not. Majority of people with diverticulosis will form these pockets. They won't be aware of them. They might be picked up incidentally during a colonoscopy exam for screening or maybe on a CT scan done for other reasons. The times where people become aware of them clinically are if they develop complications from diverticulosis, and that's where the term diverticulitis comes in. Itis of anything, as you know, is inflammation of that thing. So diverticulitis is inflammation of a diverticulum, which usually occurs at a single pocket.
So when you have diverticulitis, it's usually one of those little outpouchings, even though you've got several of them. So you don't have diverticulitis of 10 or 15 of them.
That's correct.
At the same time.
That's correct.
Why do they become infected?
So it's controversial, actually. We used to think a long time ago that these pockets would sometimes collect stool debris, sometimes seeds, nuts, popcorn. That's a myth that's been propagated for a long time. And then you would get an abrasion at the dome of that diverticulum. That wall of that diverticulum is very thin, and then that would allow a hole to form and then contents within the colon to go outside, which then causes an inflammatory reaction.
So those can pop. They can make it where what's inside the colon goes into the abdomen?
Correct, usually through a very microscopic hole.
And so it sets up an inflammatory reaction that we call diverticulitis. So is that dangerous? What are the symptoms? How does somebody know if they've got it?
Usually patients will have some discomfort in their lower abdomen. If it's a very mild case, if the hole is very small and just a little bit of a reaction occurs, they might feel some discomfort, a low-grade fever, and then it might even get better on its own if they just simply change their diet for a few days and take it easy. More severe cases where the hole's a little bit bigger, more bacteria leak out, can produce a pretty significant reaction that causes a higher fever, more abdominal pain, pain to the point where they really can't tolerate it at home and have to be seen at the doctor's office or in the emergency room.
Usually on the right side or the left side?
So because of the fact that most diverticular pockets form on the left side and the pressures in the colon are higher on that side, most diverticulitis episodes also occur on the left side in the United States and other countries where this is a common disease.
So somebody has tenderness and pain in the left lower quadrant, fever?
Fever, sometimes low grade, sometimes high grade. Again, it depends on how much of an inflammatory reaction you get. And that pain is usually on the left side. It can also be described in the lower mid-abdomen, just above where your bladder would be, if it's in the lower part of the sigmoid colon, which can sometimes swing into the middle.
Tenderness?
Usually tenderness on palpation, which means if you yourself push on your belly or you have a doctor push on your belly, you'll often feel quite a bit of tenderness in that area as well.
Change in bowel characteristics, diarrhea, constipation, what do you have as far as that goes? Bloody stools?
Yeah, usually if a patient's going to have any bowel complaints, it's going to be constipation. It's rarely ever diarrhea unless there's some other level of infection within the colon lining itself that's superimposed. Bleeding is rare also. It's not really a common complaint unless you have a different complication of diverticular disease, which happens typically when we're a lot older, where you actually have hemorrhage from a diverticular pocket. But in cases of diverticulitis, bleeding is uncommon.
So you can get bleeding, but it's uncommon. So how do you know that it's not something else going on? How do you know it's diverticulitis rather than some other inflammatory colon problem?
It's a great point. There's certainly other things that can happen in the lower left side or lower midline of the abdomen that can be confused for diverticulitis. In women, there could be gynecologic causes for pain, like a ruptured ovarian cyst. In anyone, you could have potentially a kidney stone that's passing that might produce pain on that side. And so, the best way to figure it out is to see a doctor, get it checked if it's severe, and then potentially have an evaluation done, which might include something like a CAT scan. CAT scan would be the most appropriate and usual first diagnostic test that would be done in the case of suspected diverticulitis.
What would a CAT scan look like? You've got the colon is a tube that's there, and we've got outpouching from the inside of the tube toward the outside. What does the CT scan show you? A little grape there or what?
So usually on CT scan, when somebody comes in with pain in the lower abdomen, the radiologist will focus in that space and they'll look at those cross sections that show you the sigmoid colon, and you'll actually see some of those pockets coming off the colon wall in that general region. What the radiologist looks for in order to make a diagnosis of diverticulitis is typically a single pocket that has a very pronounced level of thickening around it. They call it stranding outside the colon. And that's usually correlating with some of the fatty tissue that's outside the colon that is now infected with some of those bacteria that leaked out of the colon.
So what is the patient telling you when they come in? They've got belly pain, you ask them where it is. Then what key questions do you ask them to determine in your mind, I think this is probably diverticulitis?
One of the things we ask them is if they know they've had a history of diverticulosis before, or if they've ever had a history of suspected diverticulitis in the past. That automatically increases the suspicion. We like to know if the pain syndrome they're having matches a previous history of the same thing. Does the story sound the same? Does it feel like it did the last time? That helps as well.
Is this a recurrent illness? I mean, will it come every other year or several times a year? Or what's the long-term history?
The natural history for most people is they'll have one episode, and if they go through some lifestyle modifications, they may never have another one again. That's the majority of cases. There are a few, 5 to 10% or so, that will develop recurrent episodes over the course of time. Some of them will actually have difficulty getting over any single episode and continue to have pain in the left lower abdomen that truly never completely goes away. It may decrease in intensity, and those patients may have a so-called smoldering diverticulitis, and they may need either prolonged antibiotics or even a surgical consultation.
So prolonged antibiotics, if somebody has a mild case, how do you treat that? I would tell you, you've got an inflamed end of the colon, and so you have to go through what kind of diet, what kind of antibiotics, what do you use? What do you do?
We'll typically advise the patient to increase their water consumption. as opposed to what we tell patients with diverticulosis in general when they don't have any complications, which is to consume a high fiber diet. We will usually tell people with actively inflamed diverticular disease, diverticulitis, to cut back on their fiber a little bit to sort of rest their colon, make it a little bit easier for the colon to work. And then we'll ask them to typically take 2 oral antibiotics that are specifically targeted towards the types of bacteria that tend to be in the colon and therefore leak out to cause this problem.
How long courses of antibiotics usually? 10 days or 2 weeks or?
It varies. 10 days probably would be appropriate for mild cases. For more severe cases, 14 days. For anyone that's been in the hospital and required IV antibiotics, they may be in the hospital for 2 or 3 days and then go home when they're feeling well, and they may be extended to a full 14-day course of antibiotics as well.
So these are mild or moderate cases we've been talking about. Are there complications that can occur from diverticulitis?
Certainly. So if you have an episode of diverticulitis that involves a significant exit of bacterial burden into the space around the colon, you can actually develop an abscess, which is basically a pocket of pus outside the colon.
And that's what we're going to be talking about. What are some of the problems that we've already mentioned? Abscess. You get an abscess, how do you treat that? What's done for that? And there are other problems that can occur that we'll learn about with diverticulitis. You'll want to stay tuned. We're talking with Dr. Raj Narayani, and we're talking about the difference between diverticulosis and diverticulitis. Diverticulosis is an outpouching from the inside of the colon toward the outside, so you've got a little bubbling more or less there, or a grape size or 1/4 of an inch size little bubble that occurs. If those get inflamed, that goes from diverticulosis to diverticulitis, and that can be irritable, painful, low-grade fever, can be really very, very difficult. Differential diagnosis, you have to think of other things that can go on in that area. We're talking about complications, and you mentioned abscess. So how often will diverticulitis go into an abscess?
Typically, about 5 to 10% of cases of diverticulitis will evolve into something more complicated like an abscess.
How big does the abscess get to be?
It can be small, and it can be just within the wall of the colon itself and surrounded by some of that fatty tissue that's around the colon. Bigger abscesses, we're talking maybe 2 inches, 3 inches, are far less common, but certainly much more dangerous.
The danger would be because of?
Potentially seeding the bloodstream with bacteria, creating problems like sepsis.
So will the abscess, is it very, very painful? Is it, can you tell right away if fever spike up? How do you know if how do you suspect an abscess?
Almost everyone will have a high fever with an abscess because there's such a significant bacterial burden in a small space. Most people will have a significantly higher level of abdominal pain than you would expect from a milder case of diverticulosis. And for the larger abscesses, you may be able to palpate it, feel it when you push on their belly. And in that case, then of course, that's an indication for an immediate CT.
So if you get a CT and it says you got an abscess, what's the treatment then?
So the treatment for abscess development in diverticulitis is a little bit different than just garden variety diverticulitis, because abscesses in general, regardless of what they originate from, tend not to be treated as well by oral antibiotics. Oral absorption of antibiotics and then entrance into the bloodstream typically doesn't achieve the concentrations you need to destroy all of the bacteria in an abscess cavity. So most abscesses are going to either require IV antibiotics.
Therefore hospitalization?
Hospitalization with IV antibiotics. And then in many cases also drainage using a needle through the skin directly into the abscess cavity in order to leave a drain that pulls all of that pus outside.
So you can stick a needle in and leave a drain so it can guide the material outside. Do you ever just drain it and pull the needle out?
Sometimes for small abscesses that's possible. The radiologists usually do this for us, and when they do, if they can actually see the cavity evacuate completely and close, then they can usually go without the drain. But most abscesses are going to require temporary drainage, and typically as that drain exits an opening on the abdominal wall, which is very small, it'll be hooked up to some sort of suction bulb to continue to put negative pressure on that abscess cavity and help empty it completely.
So diverticulitis can develop an abscess. I always think about diverticulitis and a fistula. Well, teach me, what is that? Am I thinking correctly?
Yeah, so fistulas are a little bit different than abscesses because abscesses are simply walled off collections of bacterial material and anything else that exits the colon. Fistulas occur when you have an inflammatory reaction near the colon, and that part of your colon is adjacent to or next to another organ in the abdominal cavity in a way that allows a connection to form. So in many cases with diverticulitis, because of where it is in the lower part of the colon, the bladder, the urinary bladder might be involved.
Wow.
Any lower pelvic structure might be involved. And when that happens, what you get is a tunneling, essentially, of this opening in the colon wall from the diverticulum directly into the other organ, and then a translocation of the bacteria through that tunnel. And so in the case of the urinary bladder, which is usually a sterile location, you can develop bacterial infection in the bladder also. We call that cystitis, and that causes urinary tract infections for people.
So fistula can go into the bladder. Where else would they normally go? Can they go into another part of the bowel, the part of the gut?
Yeah, if there's a loop of small intestine next to the colon in that area, you can get a connection between two loops of bowel. That can produce problems because the bacterial colony counts within the lining of your colon are significantly higher than they are in the small intestine. There's bacteria in both places, but there is a difference in the numbers. And so if you increase the bacterial counts within the small intestine, you can develop some digestive symptoms that way as well.
Do you ever get a fistula that goes in 2 or 3 different directions, like one goes toward the bladder and the other one goes to small bowels? Sounds like this is pretty dangerous.
You can see fistulas that are more complicated, longer, certainly with multiple channels. In diverticulitis, it's usually one channel. If you see a situation where you have multiple fistulas, it begins to make us wonder about another condition that can sometimes mimic this, and that's Crohn's disease.
So Crohn's disease can be a mimicker of this type of situation. I want 2 other questions, the questions that are of interest to me. When you do a colonoscopy and you're looking at the colon, can you see the outpouching? Can you see diverticulosis? And can you see if there's the beginning of diverticulitis?
You can actually see both. Diverticulosis is very commonly seen during colonoscopy because it is such a common condition, and the majority of people that we do colonoscopies for are over age 50 because of screening for colon cancer. So if you have a 60% prevalence rate of diverticulosis, let's say for patients 60 and older, then you can expect 6 out of 10 people who are having a colonoscopy after age 60 to have diverticulosis. And they are readily seen during colonoscopy. In fact, in some cases, when you have more moderate or severe cases of diverticular density, you'll have a little tough time navigating through the sigmoid colon to make sure that you're going up the tunnel rather than into a diverticular pocket.
Wow, so it can be tricky from that situation. Now, I'm taking that abscesses and fistulas and diverticulitis that's recurrent. There are things that we do to try and prevent it from occurring, and there are times where we may need surgery. When was surgery ever needed?
So surgery is usually indicated for a couple of reasons. Number one would be a complication of diverticulitis like an abscess or a fistula that doesn't fully resolve with medical treatment. In those cases, with an abscess, a surgeon may go in and drain the abscess completely and then resect the segment that generated the abscess in the first place. And hopefully, in most cases, reattach the 2 ends of the bowel that are now separated so that the patient doesn't need a colostomy bag. In some cases of diverticulitis with abscess, if the abscess is quite large, or if there's peritonitis where you have bacterial infection freely floating in the abdominal cavity, the surgeon may need to form a colostomy because when you create the junction between the 2 parts of the colon in that circumstance, it often doesn't stay together.
So if somebody has to have surgery, or if you're afraid somebody's diverticulitis is recurrent, getting worse, are there any preventive measures? What do we tell us to do as far as the GI tract to quiet it down for a couple of years, 3 years, 5 years?
So, it's an interesting notion because we've never truly known exactly why diverticulosis forms in the first place. We believe that it's increased pressures in the lower left colon. Why those pressures increase may be because of low fiber, but it's controversial. And so fiber has been a mainstay for treatment for many years, and we advise it in all of our patients in whom we identify significant diverticulosis. There is a couple of studies that have shown that if you increase dietary fiber intake, that you can actually reduce the risk that diverticulosis will transform into a case of diverticulitis. So if a person has come in with an episode of diverticulitis, it was simple and easy to treat and they're well now, we will sometimes advise them on a fiber diet as well to try to help prevent the next episode from occurring.
Losing weight and smoking?
Those will probably help because they have been associated as risk factors for causing the first episode of diverticulitis in someone with diverticulosis.
How common is diverticulitis in a gastroenterology practice? Is it something you see frequently or as rare as hen's teeth?
It's extremely common. It's the most common colon condition we identify. It's even more common than colon polyps in the United States and other Western or industrialized countries. Far less common in countries out of Asia or in parts of the world where maybe the dietary fiber content starting from youth is quite a bit higher. But for a gastroenterologist, both the identification of diverticulosis during a colonoscopy or the identification of diverticulosis complications like diverticulitis, very, very common part of our practice.
Raj Narayani, you're a great teacher. I've learned a whole lot about diverticulitis and diverticulosis and about the possible complications. Thank you so much for coming to the Dr. Bob Show.
Thank you once again for having me.
A lot of information, a lot of things that I learned in this show. Now you're going to want to stay tuned. We're going to be talking about wake-up call. Is your blood sugar too high? Well, it could destroy lots of parts of the body if you don't take care of that. And a new finding on the aortic valve, a type of cholesterol that could damage the valve. A lot of questions and answers for you, the viewer. You'll want to stay tuned. I want to thank Dr. Raj Narayani. Wonderful discussion on diverticulosis and diverticulitis. Thanks. Now, questions from you, the viewer, that I think will be important to your health. Dr. Bob, how dangerous is mild diabetes? Well, sometimes there's a little humor in that mild diabetes question, because diabetes is diabetes. Let's talk about it. There's type 1 diabetes that's insulin dependent, and there's type 2 diabetes that's usually controlled by medications. Usually type 2 diabetes is in people that are overweight and they simply have insulin resistance. Now, both types of diabetes can cause terrible damage to the eyes and vision, terrible damage to the kidneys, terrible damage to the vessels that go to the toes and to the feet. It is a devastating illness. It can cause glaucoma, cataracts, increased incidence. It causes confusion in the brain from blood vessel disease in the brain. So how dangerous is mild diabetes? Let's talk about what is diabetes. We like for our fasting blood sugar, first thing in the morning, to be less than 100. If it's between 100 and 126, we call that get worried about diabetes, pre-diabetes. If it's greater than 126, you've got diabetes. And it's a wake-up call. It's the time that you see your doctor, that you get your blood sugar under control, that you do what he says, that you lose weight, that you start eating properly, that you become more active. Because if we have type 2 diabetes, where the blood sugar is just a little elevated, we can actually alter the course and make it where the problems with diabetes can go away. Now, there's a hemoglobin A1C or an A1C, and the A1C should be below 5.7. That's the cutoff. If you're above 5.7, then the chances of your getting diabetes or having diabetes in the very near future are great. It's the bottom line. If you're told that your blood sugar is elevated, that you've got mild diabetes or pre-diabetes, take advantage of knowing that you can get that better, you can improve your life, but you have to work out a plan with your doctor. Do a good job. Second question, Dr. Bob. My father has aortic stenosis. What's that? Well, the big pump is called the left ventricle. It pumps blood out to the rest of the body through the aortic valve. That aortic valve can have problems, and we now know that it can become calcified. And the calcification of the aortic valve seems to be from a form of cholesterol. Remember, we have an HDL, good cholesterol, LDL, bad cholesterol. If we take the bad cholesterol and divide it up into what we call lipoprotein A, then these are the people that seems to drive the aortic valve to get calcification and stenosis. We don't have treatment to lower lipoprotein A yet, but we're working on that. Well, it's all the time we have. Remember your exercise. Boy, if there's one thing that can help your life, it's exercising on a regular basis. It will decrease stress, decrease your blood pressure, make you feel better, make the people around you feel better. Get 7.5 hours sleep. If you're not sleeping 7.5 hours, then you need to find out why, and you need to talk that over with your doctor. It could be you don't know how to sleep. Could be the room is too noisy, it's too dark, there's too much other things bothering your sleep pattern, like pain or like medications. Be sure you are eating properly. Eat more fruits, vegetables, foods with high fiber, whole grain foods. And most of all, what is it we like in the Dr. Bob Show? It's that giggling, it's that laughter in your life. If you laugh a lot, you'll be happier, and the people around you will be happier, and you'll be healthier.